All right, welcome back. Bree, I have a question for you.
Shoot.
Okay, so why did the cross-eyed teacher quit her job?
Why?
She couldn't control her pupils.
Oh, my Lord.
Okay,
Okay,
all
I
right.
got one for you. I don't normally surf the internet, but when I do, I browsers.
All right, this is good. All right, I've got one more.
Okay.
Sometimes when I close my eyes like this,
hmm
I can't see. I can't
Or
see
was
anything.
it or was it more like this one?
That one might have been a not so good joke. I'm sorry. All right. Okay. Well, all right. The bone doctor and the eye doctor were telling each other jokes. The bone doctor's jokes were humorous, but the eye doctor's jokes were cornea.
I can't decide. This one and this one.
It's like it takes you a second, right? It takes a second. These eye jokes are they're tricky, but thank you everyone for being here. Thank you, Bree. We are back to our final session, so welcome back. Thanks for humoring us. We had some comic relief behind the scenes. We had to get it out.
That's right.
We are here to hear from our two speakers that are presenting in our final session, and they're going to be explaining the uveal melanoma genetics. So Dr. Jamie Jessen and Dr. Basil Williams are going to be presenting together, and we are thrilled to have them here. So let me go ahead and introduce Dr. Jamie Jessen. She's obtained a Bachelor of Science in Biology from York University and a Master's in Genetic Counseling from Newcastle University, Australia. Jamie has earned certification from both Canadian Association of Genetic Counselors and the American Board of Genetic Counseling. A counselor providing patients and families with the information that they require to make informed decisions. Jamie is a resource to both healthcare providers and patients as her role as a medical science liaison at Impact Genetics. Jamie's passion for the provision of support and specialized medical knowledge complements the high quality genetic testing services currently offered by Impact Genetics.
Thank you so much. And I'm sorry if I interrupted you. I lost audio there for a second, so I thought you were finished. But we're going to have first Dr. Basil Williams Jr. He is the Mary Knight Asbury Chair of Ocular Oncology and an assistant professor of ophthalmology at the University of Cincinnati College of Medicine in Cincinnati, Ohio. He's also the co-director of the retinoblastoma program at Cincinnati Children's Hospital Medical Center, and he's published over 40 peer-reviewed manuscripts and several book chapters. His research interests pertain to adult and pediatric surface and intraocular tumors. So let's give a warm welcome to Dr. Basil Williams.
Thank you so much for being here.
Thanks so much for having me. I really appreciate the invitation and the opportunity to speak with everyone today. In particular, Melody, thank you for the invitation. So, as was mentioned, I'm in Cincinnati and I'm an ocular oncologist there. And so I interact with a lot of patients when it comes to a new diagnosis of uveal melanoma. And we kind of go through the process of the diagnosis, the treatment, and then kind of answering questions and how we'll proceed from there. So, this talk is primarily focused on the genetics of uveal melanoma and how I approach that conversation with the patient and kind of how we process that information, etc. So, this is how we present it in the ophthalmology world. We talk about uveal melanoma. It's the most common primary malignancy, even though it is quite rare in the US, being only about 5 to 6 cases per million. The median age is about 60, and we'll come back to that a little bit later. And many patients are asymptomatic, and so this can be a very difficult time as a lot of patients go in to see their optometrist for a regular glasses check, and then they're noted to have something in the eye, and then pretty quickly they end up getting referred to me. Other times there's a vision change, and sometimes people know it's a little bit concerning, and sometimes people think that it's just age or the need for new glasses or possibly cataracts. And so we know that uveal melanoma is predominantly found in the choroid, way in the back part of the eye, but it can be found in the ciliary body and iris as well. And so we then go into treatment options when I see the patient after we've already made the diagnosis of uveal melanoma, and we kind of let them know that there's a wide range of things that can be done. Now, primarily in the US, plaque radiotherapy is the most common option, and radiotherapy in general throughout the world is what's used to treat about 95% of these tumors. So that includes plaque radiotherapy, proton beam radiotherapy, stereotactic, and other things. Whereas eye removal is usually reserved for patients with very, very large lesions, especially when there's already effects on the vision. So patients want to know, well, if we're choosing these options, usually there's, a group of patients that says, I want the eye out immediately because I think that's going to get rid of disease best. And then there are other patients that say, I really want to do whatever I can to keep my eye for obvious reasons. And so ocular oncologists and ophthalmologists that are treating this, we feel pretty good about local control. We know that with either plaque radiotherapy or with proton beam treatment, we're able to successfully kill the tumor in 95% of cases, which does mean there's about a 5% lifetime risk of the tumor coming back. And so when patients hear this, they at least feel more comfortable with the local treatment, with the globe sparing treatment, or the opportunity to keep the eye in these scenarios. But then patients also want to know, well, what about the risk of metastasis or spread to other parts of the body? So again, even though the primary cure rate locally is about 95%, we know that up to 50% of people can develop metastasis by 10 years. And so when patients hear this information, it obviously can be a bit concerning. And we know that the locations most commonly affected are the liver, and followed by the lungs, and then a few other locations. And so patients wonder at that time, well, what does this mean for other parts of my body? Many patients have not had any other disease and therefore have not had other parts of their body imaged at this time. And so we let them know truthfully that only about 3% of people have detectable disease elsewhere at the time of diagnosis, basically meaning the vast majority of patients do not have cancer in any other parts of their body, and the eye is the only location. Well, so patients obviously want to have the scans done of the rest of their body to make sure that nothing is going on at that point. But then comes the next question. If there's a really good chance that the tumor is cured with local radiation or with eye removal, and if I don't have any detectable signs of metastasis at this point, why would there be a chance of metastasis down the road? And so what we understand now is that with uveal melanoma, sometimes it can send cells to other parts of the body early on through the bloodstream. And there's a number of factors that affect whether or not those seeds grow in other locations. And one of those factors is how aggressive the cells are of the tumor. And one of the ways that we can assess that is by doing a biopsy of the tumor and sending that biopsy, that information out for molecular testing or for genetic results so we can analyze how aggressive the tumor is and therefore have a better understanding of what the likelihood is of this tumor spreading to other parts of the body. So, one of the main reasons why we do this, obviously, is to understand people's risk profile. So those patients who have a low risk of spread to other parts of the body, they feel a little bit more comfortable and have an understanding that even though it is still theoretically possible, depending on the risk profile, that there is a potentially lower risk of spread, and that allows them to have some comfort. We also know that patients who have a higher risk of spread, there are some options that we can have for them down the road. So, first, we kind of base how often we check the rest of the body on the results of the fine needle aspiration biopsy. So, on the results of the biopsy and determining how aggressive the tumor is. Then, if there is a potentially high risk of spread to other parts of the body, there are ways that we can approach that and try to reduce that risk of spread with various clinical trials to see if that provides any benefit and thereby reduces the risk moving forward. And so in my practice, I use the gene expression profile test. And through Castle Biosciences, there are three different tests that are offered when you get a biopsy of the tumor. So, we essentially talk about the biopsy. And usually for me, this is done at the time of treatment with radiation. And so everything is done in the same scenario. And then we, in our follow-up visits and our post-operative visits, we talk about the results of the genetic testing. And so there are three main genetic tests, and we will kind of go over each of them. So the Decision DX-UM, and that's the gene expression profile test, the Decision DX PRAME testing, which is an optional add-on, and then the uveal melanoma sequencing, which is also an optional DNA sequencing test as well. So the gene expression profile test, this is kind of one of the most commonly discussed tests. And part of the point of this is to analyze the unique biology of the patient's primary tumor, as we said, to determine what the risk is that the eye cancer will spread to other parts of the body. And this is obviously one of the most important questions that patients have when they come in to be seen, family members included. And so, what do we know? So, this was originally tested a little over 10 years ago, and it was done through a number of centers. And we basically were able to break down the primary tumors, so the intraocular melanoma, into three basic categories. So, the class 1A has the lowest risk of spread to other parts of the body. You can see over here on the graph on the right hand side that there's about a 2% risk of spread over the first 5 years. Excuse me. So in this section, patients often feel a lot more comfortable with the biopsy results. They often breathe a little bit of fresh air and say, okay, well, there's a low, but not 0% risk of spread. And so we often do systemic surveillance or imaging of other parts of the body on an annual basis. And then there's the class 1B profile, where there's about a 20% risk of spread. And so patients have an understanding that it is something that is possible and perhaps needs to be checked a little bit more frequently. And we often do systemic surveillance on a Q6-month basis, basically meaning every 6 months or so, we analyze or assess the rest of the body. And then there's the class 2, where there's about a 70% risk of spread. And obviously, in this category, because there's such a high risk of spread to other parts of the body, not only do we analyze the rest of the body on a more frequent basis, usually every 3 to 4 months, but we also talk to patients about the possibilities of clinical trials moving forward. And this would be potential options for ways to try different medications to see if that reduces the risk profile of developing melanoma in the future. Now, currently, this is still in the clinical trial space, and basically, we're still analyzing these medications to see how much of a benefit there will be for these patients moving forward. Hopefully, in the future, we will have better or proven adjuvant treatments, and then instead of it being on a clinical trial basis, we'll be able to use these genetic results to actually tell patients or to guide them to appropriate treatment modalities and discuss the ways that this might reduce the risk of metastasis in the future. Now, it is really important to state that this test is performed before the tissue has been exposed to radiation. So one of the important caveats in this scenario is when we're talking to patients about this, we let them know that the biopsy has to be done before radiation treatment is performed. So for any patients who are concerned about the biopsy for any reason, and they're trying to decide if they want to move forward with the biopsy or not, we can have an extensive discussion about that, but that decision needs to be made before treatment with radiation, as it has not been proven or it has not been studied prospectively after radiation has been performed to determine how that affects the cells of the primary tumor. Okay, so this was studied prospectively by the Collaborative Ocular Oncology Group. At that time, there were 12 centers, and the study involved about 460 patients, and it basically broke down the patients into two basic categories. So the class 1, which had a lower risk of spread, and then the class 2, which had a higher risk of spread, as we've already talked about. And you can see here that it breaks down in approximately a 2/3 being a lower risk of spread and about 1/3 being a higher risk of spread. You can see here kind of this Kaplan-Meier metastasis-free survival graph on the right of your screen. And you can see that class 1 has a very low risk of spread versus class 2 having a significantly higher risk of spread over time. So this was studied prospectively and was found to be an important independent predictor of metastasis compared to a lot of the other factors that are assessed. So This is supported by a number of scientific publications, and a number of ocular oncologists use this to assess disease. It is accurate. It provides very consistent performance. And then we know it's also clinically useful. So we talked a little bit about how we assess systemic surveillance afterwards. So how we look at other parts of the body based on the results of this. Additionally, there are some centers that are using the gene expression profile test to determine what they want to do with treatment. So when you have a slam dunk, easy diagnosis of melanoma, that conversation is a little bit more straightforward. However, not all melanomas are very obvious. Sometimes it's kind of on the border between a nevus, or a mole essentially, or whether or not it's a melanoma. And some patients, some physicians are using this biopsy and using the class to help them determine or how to approach moving forward with treatment. Now, as I said, it was prospectively studied, looking at the risk of metastasis between the class 1 and class 2. So it has not been prospectively studied for determining treatment, but sometimes it is being used in that way. Now, here are the National Comprehensive Cancer Network guidelines with the updated version for 2021. And it looks at uveal melanoma, and it looks at the risk of distant metastasis. And based on that, it also kind of helps guide, or helps perform guidance, deliver guidance as to how often systemic imaging should be performed. And this is kind of the model that I use in what we just talked about. So there's a number of ways where you can determine if a patient is low risk, class 1A being one of them, a disomy 3 or a gain of chromosome 6, looking at chromosomal analysis, and then the EIF1AX mutation, which we'll talk about a little bit later. The medium risk being class 1B, and then the high risk being a class 2. And their recommendations are kind of what I essentially follow, with the low risk getting evaluated once a year, the medium risk being every 6 months, and then the high risk can, be anywhere between any 3 to 6 months, and that depends on the patient, it depends on our medical oncologist, and it depends on the patient's primary doctor as well. Okay, so what about patients and their perspectives towards gene expression profile testing? Now, 90% of patients were surveyed, and they wanted information at diagnosis. And this is something that we presented at ARVO recently. And of the surveyed patients, 99% reported that they gained value from their test results. This is actually quite interesting, because it is not only the patients who have a low risk of spread, where they feel a little bit more comfortable, but it also involved patients who had a higher risk of spread in that class 2 category. They actually felt like they had relief from uncertainty. They were able to plan things better, and they felt more involved in their care in terms of deciding their systemic surveillance pattern and deciding what to do about clinical trials moving forward. So it seems to be something that actually benefits patients of all stages or gene expression profile classes, whether they're at low risk or higher risk of spread. So what about the optional PRAME testing? So this is something that has become more in vogue lately, and we understand that PRAME is associated with a higher risk of metastasis. It helps us differentiate a little bit the class 1 patients, and it also lets us know for the class 2 patients, if they're PRAME positive, they're more likely to develop metastasis at an earlier stage. And so we don't truly understand the differentiation of PRAME just yet. We know that it plays a role in each of these groups, but this has not been prospectively studied at this time. But that is something that is ongoing now, and I'll talk about that in just a second. So what about optional DNA testing? So we know that you have melanocytes. They're basically pigmented cells. And in order for that to turn into a nevus, or the precursor of a melanoma, there are certain mutations that need to develop, these G protein mutations that are here. So we're looking at those in the sequencing test, and then there are 3 different mutations that can happen, with the EIF1AX leading often to a class 1A, an SF3B1 often leading to a class 1B, and then a BAT1 often leading to a class 2 tumor. And so by looking at these different DNA mutations, we're able to have an understanding not only of who is likely to develop metastasis, but also we're able to target specific areas with with medications and treatment options. And so that's something that is ongoing at this point. And so, like I said, based on these DNA mutations, we're able to determine who has a risk of developing metastasis. And so, used in combination between the gene expression profile testing with the class 1 and class 2, adding PRAME, and then potentially looking at DNA mutations, we will be able to give patients a really, really good idea of the risk profile in the future. Now, some patients have asked when we talk about BAP1 mutations if this is the same as a BAP1 germline mutation. And in fact, what we're talking about so far is just in the tumor. Now, BAP1 predisposition syndrome is basically a genetic mutation that can be passed on in certain family members, through certain families. Now, patients always ask, how did I get this? And is this from somebody else in my family? So one of the conversations that we have is there anyone in the family who has a history of ocular melanoma? And sometimes I even ask if anyone's eye has been removed, because not everyone knows the full family history. We talk about skin melanoma, we talk about lung cancer, and we talk about kidney cancer. And what we realize is that if there are family members with these other types of cancer, there's a possibility that they actually have a genetic mutation in the blood, so throughout the body, that potentially increases the risk of developing melanoma inside the eye. This is found in only 2 to 3% of uveal melanoma patients. And this, like I said, is different than when you find a BAP1 mutation that's in the eye, which increases your risk of metastasis. So when you have this in the blood, it is something that you need to be checked for other potential cancers, and it's separate from the biopsy of the tumor itself. So the next step of the collaborative ocular oncology group is looking at PRAME validation as an independent prognostic predictor of metastasis, and looking at these DNA mutations that we just talked about. So we've already stopped enrollment in this trial, and we have over 1,700 patients throughout a number of centers, greater than 25 centers in the US and Canada. And the goal is to establish the best combination of biomarkers so we can evaluate patients on an individual basis and basically get good precision medicine. So I'd like to thank you for listening to my talk, and I'd be happy to entertain any questions after Dr. Jessen gives her presentation. Thanks so much.
All right. Well, thank you so much, Dr. Basil Williams, for being here. And next up, we have Jamie Jessen, who is our genetic counselor. So we're going to go ahead and say goodbye to Dr. Williams for a moment and just throw it back over to you. Go ahead, Jamie.
Hello, thank you very much again for the opportunity. I hope my slides are up. I think I just share my screen, or do I just go through it?
You're going to need to go over to your slides and
Okay.
or to restream and hit share your slides first, share your screen, and then pull them to full screen, and you'll be ready to go.
Okay. Can everybody see this? Just want to make sure.
Yes, we should be good. It looks like I see your full presentation.
How is that?
That's even better.
Okay, thank you. Sorry, everyone. I am not tech savvy, so thank you very much again for the opportunity. I think I may have met a few of you throughout the years, but this has always been one of my favorite meetings, so thanks for the opportunity to speak. I'm going to talk a little bit about genetics. I think Dr. Williams did such an excellent job. I'm just going to go over a little bit about sort of the differences for the impact genetic test. Some of you may have had our test, and some of the changes we've made. And then I'm going to just take the last bit of the presentation to talk a little bit about grief. I'm going to put my genetic counselor hat on, just because I know that talking with patients throughout the years, I thought it would be important to sort of touch on some topics that you might want to keep in mind as you move through your journey. So as Dr. Williams had said, and we talk about genetics, is the fact that we're looking at genetic information that's in every cell of our body. It's in tumor cells, it's in healthy cells. So when that biopsy is obtained before the plaque is put onto the eye, we take out the cells that come from that tumor, and you can see this little brainy looking piece is called the nucleus of the cell. And the nucleus contains the chromosomes, and the chromosomes are basically the DNA blueprint for our bodies. We all have 23 pairs or 46 chromosomes in total. One's from mom, one's from dad. And when we talk about uveal melanoma tumor cells, they're quite unique in that they have a couple of pretty standard chromosomal changes that we know can affect prognosis. So when we talk about, for simplicity, I'm going to focus on chromosome number 3 and chromosome number 8. And that's what the genetic test does from Impact Genetics, is looking at the actual DNA structures. And we know that some uveal melanoma cells can demonstrate a complete lack of chromosome 3 contribution. So that cell only has one copy of chromosome 3, and that's called monosomy 3, so mono for one. And then we know that sometimes they can also demonstrate a little extra, a gain of information on chromosome number 8. And so we would call that gain of 8q. And q is just describing which arm of the chromosome is duplicated. The little end is called the p end for petite, and the q end is the longer end. So for simplicity, I just thought it'd be good to kind of go back so you know what's actually being looked at in the tumor. Our test, uses what we call multivariate reporting. So when your sample is sent to the lab, your doctor will provide us with some information about you. So it's going to really talk about what age you are, which gender you are, and then most importantly, what is the size of your tumor? So what is the diameter of the tumor and what is the thickness of the tumor? And this is important to us because it's used when we calculate what that patient's risk is to develop metastasis using their age, their gender, the size of the tumor, plus the genetics of the tumor. So this is the Liverpool Uveal Melanoma Prognosticator Online, or we call it LUMPO. And Dr. Bertil D'Amato and Sarah Copeland's lab in the UK, who we developed our tests from, created this exceptional sort of validated algorithm that allows somebody to go in and put in as many pieces of information as they have. In the UK, they do a different type of biopsy. So sometimes they have more information about whether there's ciliary body involvement, mitotic rate. But we found that in North America, we really just have the basics, and that would be really considered, again, the age, gender, size of the tumor. And we also now have the information on chromosome 3 and chromosome 8, which we gain from looking at the tumor and looking at the chromosomal status of the tumor. And so our new reports, and some of you may have had the new reports, some of you may have the old reports, which I'll talk a little bit in just a minute. But basically, what the LUMPO survivorship algorithm was going to calculate is what is that person's individual survivorship prediction at year 3, 5, and 10. So this person's going to be given a chance of being alive and well at 3, 5, and 10 years. And then they're going to be given what is your risk of passing away, not just from metastasis, but also from just human being causes, what we would call general mortality risk. So we tease out what is the risk that you will develop metastasis and pass away from metastasis, as well as what is the risk that you will pass away just from your age and gender. And that's sort of a population statistical number. So a lot of patients feel like that might be, it gives them a way to make it more relative, sort of puts it in perspective sometimes. So it's teased out by providing that multivariant analysis. Some of you, and any of you that probably are here, may have done the test a couple of years ago where we only had chromosome 3 status of the tumor to add into that algorithm. So that has been improved. So some of you may have had the results come back where you're going to see a bit simplified version of what is the chance that you will be alive and well, that's the patient, in age from year 3, 5, and 10, compared to a control or somebody that's the same age and gender as you without uveal melanoma. So it's sort of evolved a little bit. And if any of you do have an old LUMPO2 report, I put my details at the end of this. We'd be happy to reissue that report for you because sometimes it can change things a little bit. And as Dr. William talked about, we utilize as well molecular testing. This is all part of one test for us, is we look at those mutation changes in those genes that Dr. William talked about that can be present in uveal melanoma cells. So these, again, are mutations in these genes. Genes are the small set of instructions that are enclosed within that chromosome. So normal healthy cells will not have mutations in these genes. They typically are only in tumor cells. And in uveal melanoma cells, about 95% of them will have a variation or a change, or actually specific changes that we know about, in the code of one of those 4 genes, or one or two of those genes. And in our test, what we're using that for is to confirm that the tumor was tested. And when we talk about that, lots of the studies will tell you that a tumor is what we call heterogeneous. Hetero means different. So there are some healthy cells in there. There are maybe some more aggressive cells in there. I would argue the North American doctors are experts at biopsy and that they typically are extremely skilled at obtaining that tumor. But if you did grab healthy cells, let's say from around the tumor, you're expecting that healthy cell to have all normal chromosomes and they would have normal codes in those genes. However, tumor cells, they can have normal chromosomes, and many do, and are considered sort of a lower risk, but 95% of them will have a mutation in one of those genes. So by looking at a tumor cell that is showing normal chromosomes with a mutation in one of those genes, we can safely say, yes, this is good news and it is representative of a tumor cell. Again, there are a small percentage, this is not 100%, of tumor cells that will have normal chromosome and normal genes. Doesn't mean that isn't representative of your tumor, but the doctors that we work with and some of the patients like that as a last step for confirmation, and that's included in the test. So this is a little picture of one of the reports where that EIF1AX mutation that was identified was extremely helpful. This is a case where we didn't have enough DNA to look at chromosome 8, 6, and 1, but we typically do have enough to at least rule out chromosome 3. And in this case, it was a good, healthy two-copy chromosome 3 with a mutation and representative of a tumor. So if you see our website, we've got this sort of graphic up. And to simply explain it, the genetics portion is we use 2 or 3 methods. We've got the MLPA test, which is looking at chromosomes 1, 3, 6, and 8. We also use microsatellite analysis, or MSA. That's for chromosome 3 only. We will do both if we have enough DNA, but MSA can often be really helpful when there's not enough DNA to perform everything. And we do the GNAQ, GNA11, and other gene sequencing for the chromosomally normal samples. We do save any DNA that is left over, however. So some patients have asked us to go back and check these genes for whatever that might be, a clinical trial inclusion, and we can go back and do that if there is enough DNA. So again, we take that chromosome information, age and gender of the patient, size of the tumor, and issue an individualized survivorship report. So you've got your algorithm calculation and the raw data up on top. One thing that we did develop with my team, we are owned by LabCorp, and one of my colleague companies, Integrated Genetics, we decided to create a dedicated program so that patients could review the results of often these complex reports with a certified genetic counselor over the phone. And it's a free service. It is provided as part of the test. And it's something that can be booked either by the patient, or if anybody on this call thinks they might like to go back and review what they had or maybe get their report updated, I'd be happy to set you up. But it's we are doing some studies to measure whether patients appreciate this, and measuring that is showing us that we are doing a good job for our patients. So I'm just going to switch gears here. I'm going to take the genetics out and just sort of end by talking a little bit about grief. And I know that the patients I've met over the years, whether you have a good prognosis, poor prognosis, nothing is 100%. There is a lot of uncertainty left with genetic testing, no matter which test you do. And I know that we've talked over the years about grief, and I just wanted to talk a little bit about that and talk about what conventional grief, where you kind of really think about grieving with somebody's death. That's sort of the most common way to describe grief. The definition of grief, again, is defined as a natural response. I think that's important to remember. It's natural response to any loss. And that can include physical, cognitive, emotional, behavioral, and spiritual types of responses. Here is some of the symptoms that you can think about with grief. And I mean, all of us can probably just relate to a lot of these things just with COVID. But I think it's just good to think about the fact that grief is not just one symptom. It can be a combination. They come and go, but it's something that I'm sure a lot of us can relate to. But for uveal melanoma patients, I think it's a little bit different. And this Kubler-Ross grief cycle, this is what we've all trained on, and talking about these 5 stages of grief: the denial, and then followed by anger, and then a bargaining phase, Where if you kind of think about, if I did this, maybe things will be different, often followed by depression and then eventual acceptance. And everyone had sort of thought this is a linear pattern. But, now that we've done lots more research, we know that this is not the case. People go back and forth, skip steps, go back. And we know that really at the end, the cycle can often look more like this. So it's something to be expected. Grief is not something you can unfortunately skip through, but you often do go back and forth. You may spend longer in one stage than the other, and that might get shorter, but know that it's not a linear path. So again, this Kubler-Ross stages is um, thought to be maybe a little bit hopeful, I guess, that you would go in through a linear fashion and that it's actually integrated into your life. It's a long-term experience. People do flip-flop back and forth. And the hope is that it'll go from being on the forefront of your mind to somewhat in the background, but never truly gone. So this concept of disenfranchised grief, I kind of sat with because I think I've experienced it myself with some infertility struggles I've had and losses and things that, weren't necessarily really recognized as something that was acknowledged as something that could be publicly mourned. So it's described as a kind of grief that's precipitated by a loss that cannot be socially sanctioned, openly acknowledged, or publicly mourned. And I think it's important to remember a cancer diagnosis and treatment, and especially uveal melanoma, where it's fast, it's furious. It can be a big loss in itself, even if it's fully cured. So while you may have some types of grief related to, your loss, the loss you've had, the loss of the understanding of how your life should go or what your path was going to be, your view on life and how you used to feel, and not having to fearful for metastasis at some point in your life. And uveal melanoma might be even more disenfranchised than some other well-known cancers because the general public just doesn't really know what it is or that it even existed in the first place. So I just encourage you to keep that in mind, that this is a certain type of grief that may not be something that people really recognize. And the last point that I wanted to talk about was this concept of anticipatory grief. So this is sort of grief that occurs even before death or another great loss. And it's a little bit different than the after death conventional type of grief. And a lot of people find this really socially unacceptable to express this pain that they're experiencing. And it's a combination of multiple losses in terms of grief. It's not just grieving about the possibility of passing away, but it's an accumulation of losses like the loss of your companion, the fear about financial changes, loss of your dreams, what they could have been, loss of body parts or loss of body function, and that feeling of desperation and feeling shame around that. And that you're feeling guilty for grieving when things haven't even really happened yet. But these are all real, and these are real feelings. And I think uveal melanoma patients, caregivers, family, all may feel some of this at some stage. And I think it's just important to recognize it and remind ourselves of that. And I think it's important, this is the last slide, is just to, acknowledge your pain, acknowledge that if it's there. It doesn't, just because you don't cry doesn't mean it isn't painful. Not everybody cries. Not everybody grieves the same way. And it can trigger unexpected emotions. Grief is she is relentless, and you can't skip her, you can't control her. So sometimes just to understand that your process will be unique to you and that you could try to seek out as much face-to-face. I guess we don't have that as much with COVID, but use the support from the people that are with you. If you thought about somebody that you loved and cared for and you knew they were struggling, you would want to help them and let those people do the same for you that you would do for them. And again, support yourself emotionally. Take care of yourself. Give yourself a break. It's okay. These days come and go. They may last for long, they may not, but I think it's important to recognize it. And I'm going to give these to Melody. So as Dr. Williams had said about that BAP1 syndrome, if you've got a family history or you say, oh, my goodness, I've got some people, there's a great site called Find a Genetic Counselor, and that's a US-based association that you can find a genetic counselor, and your indication would not be ophthalmology. It will be cancer, because we're looking at hereditary cancer syndromes. I put on the link for that new lump too. That's free for anyone. That is available to anyone online. We just make it into a nice simple chart. And then if you want more information about BAP1 tumor predisposition syndrome, we've got a pretty good part on our website. And I'm always available if anyone's got questions or they want to maybe go back and look at their old reports. Just please do contact me directly. And that's it.
Wonderful. Thank you so much, Jamie, for being here. And I just want to take a moment and just thank you for validating what you have like had going on for us. And just really, I think it's validating to hear you talk about how normal the grieving cycle and all of the different types of grief that there are associated with this cancer diagnosis. I know just myself as a patient, that's been something that I've just kind of had to realize and then re-realize over and over and over again. So thank you for honoring that and being a safe space for that. We do have some questions from the chat, so we're going to go ahead and pull those up, and we will. I guess if you guys particularly want to answer one, then we can have you chip in. If you both want to answer, you can both just answer. We'll take them in turns. So it looks like our first question. Let's see. Okay, the first question was, how do I find out if I'm eligible for blood tests for a genetic syndrome? And I think this was addressed to you, Dr. Williams.
Okay, so this is a very good question. So first, I wanted to say thanks again for allowing me to participate. And Jamie, I've heard you speak before, and you always give such wonderful talks. And I think it's the mention of grief and kind of discussing it, I think is something that's extremely important. So thank you for that. In regards to the question and looking at genetic syndromes and blood tests, we usually focus on patients who have a family history of certain cancers. So some of the cancers that we talked about, if there's lung cancer specifically, mesothelioma, if there's kidney cancer, if there's other history of eye cancer, skin melanoma, basal cell skin cancer, etc. So if there are those types of cancers in the patient or in first or second degree relatives, or if the patient is particularly young, those are scenarios where we think it is probably worthwhile to pursue genetic testing. But that being said, in the absence of that, speaking with a genetic counselor, you can also talk about whether or not it's something that specifically makes sense, because we highlighted BAP1 germline predisposition syndrome, but there are a couple of other predisposition syndromes as well, and we're learning more about them. So I think having that conversation with your doctor, having that conversation with the genetic counselor is also, those are two helpful avenues to pursue this.
Okay, that's helpful. I do have a question about the blood test for genetic syndrome. So this is, I guess that I just answered my own question. It's a blood test, correct? And so that would be what they request if they wanted to ask for that.
Yes, that would be correct. That's a blood test.
And it does sound also like the best way to go about figuring out if you want to do one of those or if you are eligible would be to talk to someone like Jamie, who's a genetic counselor who can help you, advise you in that avenue. Okay, our next question down here says from Vicky Bush, is there a way to find out if one has the SF3B1 mutation? I had the Castle test done 7 years ago, but it was done at the time of plaque removal. So obviously it's been some time.
Yeah, so this is actually similar to what Jamie was talking about as well. When the biopsy is done, the Castle Biosciences tries to hold on to residual tissue, and so down the road, additional testing can be done if there is a sample that's left. So I think the best thing to do at this point is to contact your doctor or contact Castle, and you can talk to them directly and see if there's actually residual tissue that's left over, and then those analyses can be run. Obviously, if there's no residual tissue, then you won't be able
That
to
would
find
totally be a valid question. And it looks like Kat Alcina from Castle actually dropped a chat response here. And she said to go ahead and if they do have tumor tissue available left, just make sure, contact them, and they will get back to you. They're very easy to work with, very quick to respond. So our next question says, how does prognostic testing affect your clinical decision making? Yes.
So I think that the prognostic testing, number one, I think the treatment, at least when it's clearly defined as a melanoma, prognostic testing is not changing how I'm treating the lesion in that scenario. However, we did briefly mention in the talk that there are some times where the lesion is not clearly identified as a melanoma. Now, one of the things that's really helpful in this scenario is not only looking at gene expression profile or PRAME, but looking at the DNA mutations, like Jamie was talking about as well. You can see if you have those G protein mutations that this is in the category or along the spectrum of a melanoma. And then if it has a secondary mutation, an EIF1AX or an SF3B1 or a BAP1, that kind of lets you know pretty definitively or pretty strongly that this is a melanoma that you're dealing with. So if it's ever a lesion that's kind of on the borderline and you're trying to determine if treatment is the right approach or if watching it makes sense to see if it changes in size, then you can use some of this information to help confirm it being a melanoma. Now, that being said, that hasn't been prognostically proven, but in a lot of ways that is, or prospectively proven, I should say, but that is oftentimes how it is being used.
Okay, so that's good to know. And I believe if you actually check out our podcast episode, and feel free, anyone can reference this, but we had a Dr. Walter came on, and he talked a little bit about using the diagnostic testing to determine treatment options for a melanoma in the eye, so that in those cases where you don't know if is this really a melanoma, or is this just kind of a freckle, or do we just need to watch it? So that is definitely a really good one. This question, I think, is probably a little bit more for you, Jamie. What if, as a patient, I don't want to know my genetic testing information?
Yeah, that's a really good question, and I think that can often be a psychosocial reaction. I mean, there's a lot that comes from that, and it is a personal choice. Um, I think sometimes I would encourage, as Dr. Williams said, the best way to get information, unfortunately, is before you go through all of this. You go through your therapy and you go through the operation. It's quite traumatic. Um, I sometimes encourage people to think, there's one opportunity to get your biopsy. So, we have patients that want to think about it. Maybe even years down the road would like to think about it, not ready for it just now. To take the biopsy and send it and store it and wait. So as far as you could tell, you've got the opportunity if you want it. It will never be used, of course, for anything but your own medical management. But I think knowing from a counseling perspective that um, again, or you truly may not want to know, and that's okay too. And I mean, the physicians you work with are experts. If they don't have genetic information, they didn't for many years, they will assess you based on the size of your tumor. They will look at you as an individual and treat you accordingly. So I think it's fine to not want that information. But I will say, long-term studies have shown that bad news versus uncertainty, not knowing long-term, can create a heightened level of anxiety that you may not be expecting. So I just encourage people to sort of think about it. And if they can opt to take the biopsy and wait, that might be the best option for them. But again, it's their choice. I don't know if you would agree, Dr. Williams, but
I agree completely with that response. I mean, it's a very, very difficult decision, and I understand that there's a lot that goes into it. And like you said, if you decide to move forward with the biopsy, you can have that information held, and so you don't have to do anything with it, and you don't have to know about it. And then if you change your mind later on, then that information will be available. I agree.
Yeah, I think that would be what would have done. And I would have hoped that my doctor would have advised that. I opted to do a biopsy myself, but I do think, this is maybe a silly way to connect it, but if you're familiar in the ultrasound world and pregnancy world, if you want to know the gender but you don't want to be told right away, your doctor will hold the information. And I think that that's the case here, is that if you need the information for treatment and you would like to just be treated and have the most information possible at the best time, why not? But then if you don't feel mentally and emotionally ready to handle that information at that immediate moment, then just wait. And it's never going to hurt you, like Jamie said, to have the information available to look at when or if you're ready.
yeah.
Let's see. I feel like I see maybe one or two questions. Actually, it looks like only one more. So if I have a germline BAP1 mutation, should I assume that I have a somatic BAP1 mutation in my eye tumor? I did not have tumor testing. So it sounds like they know they have the genetic BAP1 throughout the rest of their body, but they don't know for sure because the tumor wasn't tested.
I would say yes, you will. It's the same as retinoblastoma, which is my love as well, Dr. Williams. Is that mutation is in every cell of your body. It's only in one copy of the gene. So the thought is that the other copy that doesn't have the mutation, that wasn't given to you from one of your parents, that will obtain a mistake by chance. And that's called the two-hit theory. And so now that cell has no protection. BAP1 is a good gene. It protects us from cancer. So yes, you would have a BAP1 mutation in that gene in your tumor cell, probably with another one on the other copy that was normal when you were born. And that would be something we know that people that have BAP1 predisposition syndrome have a BAP1 mutation in their tumor, and they're typically thought to be high risk. I believe that would be if you had a hereditary patient, Dr. Williams, with a uveal melanoma, it would be a high risk patient.
Yeah, I would agree with you completely. I would say that if you have the germline mutation, you can feel confident that you likely have the somatic mutation in the tumor, but that is not true the other way around. Having the somatic mutation in the tumor does not mean that you have that germline mutation.
Okay, that makes sense. Thank you guys so much for clarifying this and for the time that you that have taken out of your weekend to talk with us and to explain. We are really grateful, and we're going to let you get back to the rest of your days. So thank you so much, and make sure those of you who are still here stick around. We have a quick announcement from our board.